Hey guys, got a question today about alveoloplasty. For those who don't know what alveoloplasty is, that is where we will reshape the bone in the mouth so that it's nice and flat so people have less problems with maintenance, cleanings, risk of infection, things like that. We do take away bone, or in my case, I harvest bone and put it back into places. But I answered this question the other day and I want to go ahead and go to that question and we'll go there. Hey guys, I got a question today from Sula Linksa. Hello doctor, I have one question and I do hope you can answer. Is there such a thing of removing too much healthy bone while performing an alveoloplasty, causing the patient to suffer from exaggerated bone loss and facial appearance looking aesthetically displeasing? I do know their area is complex, but imagine the patient is overall extremely healthy, without gum disease, and relatively young, 42. Thank you. Well, Sula, let me explain this to you. So alveoloplasty, just for those who are watching this video, is a procedure we do, not just in doing ALL-ON-4. Sometimes we do it while doing dentures or for other reasons when patients have bony projections that come out of their jaw. It happens every once in a while in the lower, right below the tongue in the lower jaw and right on the roof of the mouth. We do these plasties. Alveoloplasty is more at the alveolar portion of the bone. And so what it is basically is that we're taking away bone. We're cutting bone away. Usually this is done with an instrument called rongeers, where it's almost like a scissors in a sense, and we're just clipping off the portion that we need to remove. Most of the time, this is in between the teeth. So teeth sit inside of the bone, and on all four sides, the front side, back side, and both sides, is going to be bone that's going to kind of hug the tooth, right? So as you extract that tooth, you'll have a wall in the front, a wall in the back, and you'll have both side walls. And when it kind of projects up, a scalloped bone, that's a place where it's going to be uncomfortable for the patient. Also, it also causes, when you have bone that isn't contoured or alveoloplastied, it makes it so the hygiene for the device is really difficult. And so there's discomfort, but also when you have bone that's kind of going up and down, it's going to make it so it's really hard to clean and maintain. So there's one other reason why we contour the bone. I use the word contour, or another word I would use would be harvest. Because for me, I don't just cut away the bone. I don't clip it out and throw it in the garbage, which unfortunately a lot of doctors do. We will go ahead and clip the bone, and then we'll take and grind up that bone. We'll cut that bone up into tiny little pieces, and we'll put that bone back in the patient's mouth inside those extraction sites in the depth of the extraction. So it's basically, rather than just you're cutting it away, you're really just kind of transplanting it from one position to another. You don't want a doctor not to do an alveoloplasty. Now, in regards to your question, your question is, can you do too much alveoloplasty, causing the patient to suffer from exaggerated bone loss? So, if you have teeth in your mouth, which it sounds like you do, and you made the comment that you have no bone loss, then it's more than likely you're probably not the best candidate for ALL-ON-4. ALL-ON-4 is typically going to be someone that is that has bone loss due to periodontal disease, bone loss due to trauma, and there's going to be the teeth are going to be have problems also. Sometimes you'll see that the teeth don't have any cavities, but typically what I see is there's going to be teeth that need work, cavities. There's going to be bone loss or periodontal disease. And so for a lot of people, they don't realize is that we're not having to contour, cut, or alveoplasty. Those are three words I could use pretty much interchangeable. We don't have to do that too much. Why? Because the infection or the bacteria that's in between the teeth is already done the work for us. And so that's why the gums don't look healthy and there's space between the teeth and we call black triangles. These are kind of the signs that patients would want to do some sort of procedure like all-on-4. So my question that I would ask you back if your consultation would be, why do you want all-on-4? If you have healthy bone and there's no bone loss, why not just do, why don't you just do some bleaching, some contouring? Is it because your teeth are crooked? If they're crooked, then you can do orthodontics. If maybe there's no bone loss, but the teeth have lots of cavities, which is possible, then you may want to consider doing root canals and crown and bridge. Now, I'm not a huge fan of root canals, but in certain individuals that don't have a lot of infection, they're a good option. But I would say, the reasons why people would choose to do all-on-4 in the scenario you're talking about, the only scenario I think would really play out in my mind would be if you have bone loss in between the teeth, but all the teeth are boned out. So like maybe someone that's maybe recovering from some type of addiction of sorts, whether it be alcohol or heroin, something like that, where the teeth have really been damaged, and so the teeth may be bombed out. The word we use, meaning they've been really broken down and worn down. And they've been discolored and they don't look healthy. And in term uses meth mouth. But in between the teeth, there's no bone loss. So maybe that's a scenario that we can kind of play out. But let me see. Let's just kind of play this for a second and talk to you about this causing the patient to suffer from exaggerated bone loss and facial appearance. So, okay, but let's say that there was a need to do all-on-4, and you asked a question about can you do too much alveoplasty? And you can. There's only so much alveoplasty that's needed. And something I see happening very often inside of all-on-4 implant surgery is that doctors are over reducing or over contouring or performing excessive alveoplasty. I'm trying to use different ways of saying this so that makes sense to you. And meaning that there's a rule of thumb that within all-on-4 dentistry that we want a certain amount of space for the health of the prosthetic, the health of the bridge. And so sometimes doctors will make the error of measuring this distance from the top, say from the incisal edge, the front tooth, from the edge of the front tooth up. And that would be a grave mistake because oftentimes we're changing where the edge of the tooth is going to be in the final device. So the rule of thumb is that we want 15 millimeters of space from the edge of the tooth of the future tooth, not the current one, the future tooth up, and that we want to make sure there's enough space there, meaning that we contour it down. So people that already have bone loss, oftentimes you don't have to do any bone reduction. The average tooth is about 10 millimeters long, so this would mean that you take 10 millimeters of the tooth that you see, a couple millimeters of gums on top of that, so really you're taking away maybe 3 millimeters of bone. If you look at the tip of a pencil, when it's kind of worn down, that's about a millimeter. So take three tips of a pencil when I'm not saying like a uncut tip of a pencil, or let's say a pen, right? Just a regular pen. That's about a millimeter. So take 3 of those, and that's basically where you're at. So why did I bring that up? So you can see that, if done properly, you're taking very little. Really, it's just those edges off. And then there are some patients that are extreme where we have to actually reduce more, and that's mainly because of aesthetics and that they have a high smile line. This is a really important subject, and I do see a lot of doctors making mistakes, all well-intentioned, but these mistakes end up costing a lot for the patient and cause a lot of suffering and pain when they have to have the stuff redone. So at the very end, would a good doctor that plans this out from the beginning would definitely not cause any exaggerated bone loss or any facial appearance that would be displeasing. Someone in a denture, it's been a denture for a long time. Now that could be a case where when you transfer from a denture to an all-on-4 bridge, you have to be careful because yes, the patient's been used to having a very bulky device that pushes the lip out. And so That's a different situation versus someone that has teeth. If you have teeth and you're doing all-on-4, then we should be able to maintain the facial appearance. If you're in a denture and you've been in a denture for many years, then you have to do some trial and error before the surgery starts, before the commitment's made, before the money is taken, and make sure that the patient is going to be happy with that. And I'll have to post a video at some point on that and how you kind of determine that. But it's very, very easy to do, but it's a way to show the patient how much facial support they're going to have when they have all-on-4, because a lip will change for sure, but most of the time the changes are positive enough, or the overall uh, goodness or the overall uh, experience of the patient is more positive than negative, meaning maybe the lip sinks in a tiny bit more than when they had the denture, but all the positive far outweigh the other side. And so I hope this video has been helpful for you. Please subscribe to my channel. And when you subscribe and you leave a question, you may be featured as a question I answer. And so I spend a lot of time answering questions, and we're going to continue to do this. So subscribe. So if you leave a genuine question, that I will put you into the into the mix of questions asked in the future. God bless you guys. Have a nice night. We'll see you.